Thank you very much. And thank you for the organizing committee to actually make it possible to get here. Thank you, Professor Landis, to give me the invitation to speak here and to give me the opportunity to speak here. And it's really an honor to speak at CCAS on the topic of stigma, because none of the many aspects associated with HIV get under my skin more than the stigma attached to it and the implications it has on the lives of people living with HIV, their health, their well-being, and the communities that they're part of. I just have to look here. Exactly, yes. Well, before I start my presentation, I have to give this because I have, as you see, no financial links to pharmaceutical companies or whatever. As I was listening into the presentations yesterday, I think it's also good to give you a short insight of where I come from, basically, and what the situation is in the Netherlands. As you can see, it's a very concentrated epidemic, mainly driven by gay, bisexual, and other MSM. There is the other part, basically the other 30 to 35% of the people living with HIV have a migration background in the Netherlands, and a large portion of the people of the migration, with the migration background, comes from sub-Saharan Africa, and then we have a portion of people, of course, who were originated from the Caribbean because of the former colonies and parts of the Kingdom of the Netherlands, which are still situated here in the Caribbean area. So that's basically where I come from, because when I continue with my presentation and I come up with some examples, basically, and some suggestions about how to tackle stigma, I think it's important for you to understand why I derive to basically my suggestions to you. And I was actually sort of contemplating that I could actually just take the presentation, just leave it at this slide, because I think shame is what it is about. Shame is what is behind stigma. And I'm standing here before you as a virally suppressed HIV positive, cisgender, gay, white, educated male, and I'm aware of the many privileges I have. I'm of fairly good health. I have to admit that a pause and proud man, I'm a chair of a great organization. I'm an activist. I'm not afraid to call things by their name, by the nature, of course, that I'm Dutch, so if I come across as a bit rude, I just blame it on my Dutch roots. And, you know, I have come to think that through my 35 years of self-awareness as a gay man and 15 years of being HIV positive, that I have not come out of that unscathed. As I nearly turned 50, I recognize moments of self-stigmatization in my daily life. I'm aware that I have prejudices based on stereotypes. I make unfair judgments. I discriminate. And it's a hell of a job to take a stand against that, the judgments, my shame, my self-stigmatization, my prejudice, my discriminatory behavior. But from my own experience, I can tell you it's worth it. And fighting stigma, not only my stigma, but the stigma people with HIV encounter on a daily basis in society, and especially in healthcare settings, is crucial if we want to achieve the strategic goals set by the United Nations for 2030. Sorry. Yes, like that. Even in a high-income country like the Netherlands. If we want to get to zero, we need not only universal access to medication for everyone who is HIV positive, we also need a vaccine, and we certainly will not succeed in reaching those who need care the most if we do not look into innovative ways of tackling stigma. When I got the invitation to speak to you on this subject, I was thrilled by the idea, yet it felt also as a very daunting task. What could I possibly tell you about stigma that you haven't heard or read before at another presentation? The subject is getting its well-deserved attention, professional attention. And over the past years, we've seen more and more research into stigma being published. I, for instance, couldn't have made this presentation without the scientific knowledge of and support of Arjan Bos and Sarah Starderheim from Maastricht University. And I used research from my own organization, the Dutch Association of People Living with HIV. 3 years ago, we conducted the largest peer-to-peer qualitative research among people living with HIV about their quality of life. Our association trained approximately 40 interviewers who interviewed other people living with HIV, around 500. And it's called Positive Voices. And the results are compelling, to say the least, especially on the subject of stigma and its detrimental effects on people living with HIV. You can read the online English summary, as you can see here, and because you get the presentation, you have the link to have a look at that. And before I continue, don't worry, we'll get to the more boring text slides about stigma in a minute. It's just, I have to explain that I have a background in architecture, which makes my brain work slightly different, and I concentrate on images. And as I was looking for a visual metaphor to bring across the complexity of tackling HIV stigma, after absorbing a lot of data on the subject, I came up with the metaphor of tackling stigma is as daunting as trying to disentangle a Gordian knot. Here you have it. Well, you know, metaphors are great for presentations, but they can also be a bit dangerous, I have to say, because once you start associating on the theme of ropes and knots, you might end up giving a lecture on bondage. Or, well, if you have a less, innocent mind, you might have expectations that I, the speaker, might disentangle this knot. Well, I can tell you, if there's one thing I'm not good at, it's disentangling knots. Now, the thing with the Gordian knot, apparently, was that, according to history, it was too difficult to disentangle for anybody, except for this one chap that came along and who used a very innovative way to disentangle it. Does anybody know who is the owner of this sword, actually, in the... No? Well, I'll give you a hint. It was Alexander the Great. This is a picture of a French painter, Jean-Simon Barthélemy. And I can assure you that apart from my name and the attraction we both have for men, there's nothing in common. Besides, I couldn't get my sword through the airport security, so I guess you have to bear with me while I try to disentangle this knot in a different way. And while scavenging through the internet, doing some background research about this French painter, I found something else which is very pleasing for the eye, because he also painted this, and this is called Death of a Gladiator. You see, this is a good example of how dangerous associative research on the internet using Google can be. But on the other hand, searching with images led me to this picture, and this is, I think every presentation, should at least have a picture like that in a presentation, because, it works, you get attention, and you should try it too, when you get your next presentation for an HIV conference. You will see how much more attention you will get. But all kidding aside, this beautiful yet somewhat histrionic painting brings us also a little closer to the core issues at hand when we talk about HIV stigma. For me, this painting represents a thesis that I've been using for quite a while now, which is we can relieve the burden of HIV stigma for a certain amount, but we won't be able to eliminate HIV stigma on the short term, because HIV bonds together two basic instinctual Freudian drives. Here we have eros and thanatos. So let's linger a little longer in Greek mythology, or to be more precise, the realm of Freudian psychoanalysis, when we speak of love instinct and the death instinct. HIV still connects these basic instincts, even though HIV, when detected and treated timely, no longer is a lethal disease. But there's yet another aspect we need to look into, namely religious morality. If you take into account the strong influence religion has on many societies on top of these basic instinctual drives, one gets a potentially very toxic cocktail of sex, sin, and death. The ties between sex, sin, and death are difficult to sever. Let me give you an example by looking at syphilis. Before the introduction of penicillin in 1940, syphilis used to be lethal. And now, 70 years onwards, there's still a great taboo around syphilis. And I'm just doing some research here while we're here, and I will give you a question. I just would like you to raise your hands, and I'll give you a dilemma. So you have contracted an STI, just get along with that. And you have to tell your best friend that you actually contracted an STI, because it's the thing to do. And I give you the choice between choosing that you tell your best friend that you have contracted chlamydia, or you have contracted syphilis. So he's for chlamydia. May I have some hands, please? Come on, now you have to choose. Okay, which means that the rest of the room will tell everybody that it has syphilis. Okay, thank you very much. That is amazing. So, but to be honest, there is hope. There is hope. Out of taboo and shame around syphilis have come the most beautiful works of art. It was the inspiration for the libretto of Richard Wagner's opera Parsifal. And I can recommend you to read Linda Hutchinson's essay called Syphilis, Suffering and Social Disorder, or Social Order, which is part of a book with the telling title, Opera, Desire, Disease, Death. And all of a sudden I realize why I've always been such a great fan of opera. If syphilis can be the inspiration for such great works of art, what will HIV have in store for us? Before I zoom in contemporary forms of stigma, it's good to brush up your basic understanding of HIV stigma. So what are we talking about? The term stigma dates back to the Greeks, who cut or burned marks into the skin of criminals, slaves, and traitors in order to identify them as tainted or immoral people that should be avoided. Today, the term stigma does not represent a physical mark, but rather a kind of social mark that yields widespread social disapproval. A stigma thus is an attribute or a characteristic that conveys a devalued social identity in a particular social context. It also reproduces existing social inequalities, and it is perpetuated by hegemony and the exercise of social, economic, and political power. In social psychology, stigma comprises three components: cognitions, thus thoughts in the form of stereotypes; emotions expressed as prejudice; and behavior which manifests as discrimination. Stigma comes in many shapes and sizes. I'm not going to discuss all these forms of stigma on this slide, but I wanted to show you the particular figure because all of the interactions between the various forms of stigma. If we want to disentangle the Gordian knot, we have to engage with all of these forms of stigma. The following slides focus on research by Stutterheim among migrant communities in the Netherlands. Other studies, like Positive Voices of our association, suggest that the results extend also to other communities. The results from a study show that HIV-related stigma is perpetuated by the belief that HIV is highly contagious. In fact, the interviews provided examples of how people living with HIV thought to be dirty, as well as examples of people being unwilling to use cups or plates or eating utensils previously used by someone with HIV. The second belief is that HIV is very severe. HIV was considered by many to be a death sentence and a killer. The third is the belief that people with HIV are personally responsible for having acquired HIV. HIV was considered by many to be a punishment or due justice for previous wrongdoing. The final belief is that HIV is the result of engaging in norm-violating behaviors such as promiscuity, commercial sex work, and for the Antillean and Surinamese respondents, also homosexuality. The study showed a number of consequences. First, Stigmatization impacts the psychological well-being of people living with HIV and yields not only emotional pain, sadness, and loneliness, but also anger and frustration. In some cases, the stigmatization experienced by someone with HIV is internalized. I can give you a clear example of this. In one interview, an HIV-positive man indicated that he cannot get romantically involved with anyone because he is scared to infect them. However, we know today that when you take your medication correctly and your viral load is undetectable and stable, the risk of infection is close to zero or zero. So the fear was ungrounded. Stigmatization also has social consequences. We found that stigmatization reduces the social network size of people with HIV while also reducing access to social support. Social isolation is not uncommon and is, unfortunately, often self-induced. A large number of participants reported choosing to withdraw from their own social circles so as to avoid stigmatization. A final consequence of HIV-related stigma pertains to the health of people living with HIV, as stigmatization reduces treatment adherence. Participants all too often reported skipping doses so that others won't discover that they are taking antiretroviral medication. Before I continue with a compelling example of everyday life stigma and its consequences, I will sum up the main findings of Stutterheim's study on stigma. First, 4 beliefs underlie stigmatization in various communities. These are the belief that HIV is highly contagious, the belief that HIV is very severe, the belief that people with HIV are responsible for acquiring their infection, and the belief that HIV is acquired through norm-violating behavior such as promiscuity, commercial sex work, and homosexuality. Second, wait a minute, I think I'm missing a yes. So second, stigma manifests as social and physical distance, words, and silence. Third, there are substantial psychological, social, and health consequences of HIV-related stigma. Fourth, stigmatization, be it enacted, anticipated, observed, internalized, or extrapolated to others, impacts disclosure decisions. Fifth, certain manifestations of stigma in certain contexts, particularly within families and healthcare sector, are psychologically more detrimental than others. And lastly, people with visible symptoms of HIV or the medication are psychologically and socially worse off than people who can conceal their HIV status. I'd like to give you an example of how detrimental stigma can be. Let me introduce you to Marcus. This is Marcus. I'm just going to read his story to you, so bear with me. It's quite a dramatic story, but it always gives me a bit of shivers, but okay. There was no room for gay people in the German village where Marcus grew up. Once his foster parents worked out that their ward liked men, they kept him under observation 24 hours a day. They wouldn't even let him make phone calls. 3 days after he disclosed to his foster parents, Marcus found himself in a children's foster home, and a little later, he was alone in a young people's shared flat under care. Marcus was diagnosed with HIV at the age of 18, when he was already seriously ill. For 2 years, he had suffered strong bleeding and horrific pains in his jaw. Several teeth had been pulled, but doctors couldn't work out what was wrong with him. Until Marcus, utterly desperate, changed to another dentist. And that one knew immediately. You either have leukemia or you have AIDS, he told Marcus. Yeah. Well, the HIV test came back positive. Marcus's main issue was always discrimination. He'd always experienced ostracism, hostility, and recrimination, both for being gay and for being HIV positive. It's what we call a double stigma. He heard abuse like, "It's your own fault, you're AIDS queer," more often. During a job interview, he was once asked how anyone was supposed to take on someone like him because, colleagues wouldn't be able to use the same cutlery box. And some so-called friends turned their backs on him because they thought there was no point in keeping up the friendship because he would die anyway. As many gay men like him, Marcus developed over the years coping mechanisms to help him navigate in a sometimes very hostile environment, emancipating himself step by step. Eventually, he became known in Germany as a model of the German HIV awareness campaign. But the effects of being a late presenter with a seriously damaged immune system eventually led to him getting cancer. He died 4 years ago, aged 32. That's why combating stigma, discrimination, and phobia are key elements in the HIV prevention work of Deutsche AIDS-Hilfe. They should be key elements in any prevention framework. HIV stigma in working environments is what I'm going to talk to you about next. It's my next example. Let me set the scene for you. Follow me into a dynamic Dutch working environment where 5,000 professionals and over 20,000 volunteers work 24/7 to protect Dutch citizens from being a victim of fire, flooding, and other disasters. Normally you don't see them like that, but it's a fire department. And this is a picture being taken while they were protesting to get better pay for their pension. So I'll just change to a picture which is less distracting. You know, I don't know how you or how fire departments work here on Barbados, but in my previous life as an architect, I had the privilege to actually be able to design a home for the fire department, so where they come together, where they store all the cars and where they have all the equipment and live together. And being a professional firefighter, it's that you are almost like part of a family. And you work together, you have shifts together, you eat together, you sleep together. So that is, it's complete bonding, basically. And through my work by designing this building for the fire department, I got a huge respect for the firefighters because, they're tough men, tough women, being exposed to extreme risks and, getting into burning houses, saving babies, jumping after cars. And in the case of the Netherlands, of course, we have all these canals where people drown, so they have to jump after them. So, it is a very dangerous job, and they take up a lot of risks, and they're truly, truly heroes, really. But of course, until, amongst your family of fireworkers, you find somebody that is HIV positive. And all of a sudden, that has become far more dangerous than actually trying to save somebody out of a fire, out of a burning house. So we were called by let's call him Ben, a Dutch firefighter, because there were problems at work, because his colleagues refused to work together with him because he had HIV. And which eventually, although we tried everything by getting in there with the local health department and giving information to his colleagues about that there was no actual risk of infection when you were doing your job, it eventually led to the fact that, well, he was still actively employed by the fire department, but he was no longer in active duty. He was sort of pushed aside and now has just a job at the desk, which is of course far more less risky. But that is an example of what stigma nowadays looks like in 2017 in a high income setting as the Netherlands, where you were supposed to think, well, we've come past that, we've come through that, we have the knowledge, But apparently, appealing to HIV, it appeals to inner fears which are so strong that even if you give the good information, it's difficult to come across this enormous barrier that has been put or thrown up or has been raised basically by the messaging that we have received over a good portion of 20, 30 years, telling us that HIV is deadly and that it is very dangerous. And these messages from the 80s and the 90s are so compelling, are so strong that they stuck in people's minds. So we need a lot of work to actually undo that. And you know, I don't know what it does to you when I tell you these stories, but when I hear these stories, it really makes me mad, it makes me angry, it makes me sad, because this is how people's lives are touched, not just because they have HIV, because they can manage that and they can live with that, but they can't live with the stigma. You know, that is actually hurting people much more currently than having to live with HIV. The stigma attached to HIV and AIDS and the related cognitions, emotions, and behavior are often described as a vicious cycle. Ladies and gentlemen, it's high time we started breaking this cycle. I put a lot of thoughts into disentangling this Gordian knot. I came up with some thoughts, and we don't even need a sword to solve the problem. I believe that you and I, our friends and allies here and elsewhere in the Caribbean, can come a long way by adopting what one might call a stigma action agenda. Let me introduce you the 7 E's. In Stutterheim's study, the stigma experienced in healthcare settings was found to be extremely harmful. And we've just heard an example by my colleague, Mr. Nunez. I'm just giving some insights about myself. 2 years ago, I had minor surgery performed on me. I wasn't anesthetized, so I could see the procedure. And I saw the doctor put on 2 pairs of gloves. And I just asked her, why do you put on 2 pairs of gloves? Well, she said, it's part of our policy, because it's written there. It's, when we treat somebody that is HIV positive, and I actually told them myself, it's not out of consideration, basically, which I needn't do. And well, now that I know, I have to put on 2 pairs of gloves. I think it's an outrage that in this day and age, people living with HIV who are virally suppressed are still being treated by healthcare professionals wearing 2 pairs of gloves. That dentists or other specialists are only willing to treat patients at the end of the day so they do not contaminate the operation theater. That nurses and other healthcare professionals have to be warned for patients by a large red cross on a medical file. It is demeaning and totally unnecessary. This has to stop. We, the people who are living with HIV, we need educated professionals, urgently. We need medical professionals that educate their peers. I dare say it's certainly a daunting task, but let's start by taking a small step. Check the medical procedures of your own hospital and what they say about safety procedures when dealing with HIV-positive people. If they're outdated and stigmatizing for people living with HIV, change them. Easy. In the Netherlands, a coalition of activists and sexual health and AIDS service organizations are working very hard to give speedily access to PrEP for the most in need of PrEP. Our association is a strong supporter of PrEP. Besides the very obvious reason to support this position, because we try to curb the epidemic with all means available in a sexual and reproductive health and rights context, we support PrEP because we see its potential to heal a rift between HIV-positive and HIV-negative people. This rift has divided many communities, not in the least the gay communities. By taking PrEP, HIV-negative people use the same methods and medications as HIV-positive people to stop the spread of HIV. It will eventually lead to more understanding between those 2 groups. I found an example of this online. It's, I quote a Greg Owens blog. It says, "When I was diagnosed with HIV, I refused to suffer in a world I didn't like and to do so in silence. Instead, I saw that PrEP would have as much benefit for me personally as it would for everyone else negative and positive. What PrEP does, it removes fear. And without fear, stigma starves. And that's what PrEP does. Investing in PrEP in my community totally helped me to accept HIV-positive status, knowing that it wasn't going to kill me who, what, or how I am. Emancipation of patients is at the core of the structural health improvement policy framework of the Dutch Association of People Living with HIV. Only emancipated patients can make informed decisions about their health and well-being, decide when and to whom to disclose, know how to manage stigma and discrimination. After all, in the process of stigmatization, it takes two to tango. One to stigmatize and the other to feel stigmatized. For some people, it can be a revelation that it is actually possible to reject the stigma of individuals or society, that stigma, to some extent, is manageable. It's time for people living with HIV to stand up and say, we don't want your stigma. Our Association of People Living with HIV engages with stigma on many levels, but we also engage people literally by making it possible to connect themselves with peers. Identification with similar others is well known and observed coping mechanism of people living with HIV. It reduces stress and is the first step in an emancipation process. Connecting and reconnecting people to communities, new and old, is the basis to reduce self-destructive behavior like harmful substance abuse. I am deeply worried by the lack of engagement of people with communities and substance abuse within my gay communities of gay, bisexual, and other MSM. I suspect that the high rate of suicide among people living with HIV in the Netherlands may be connected to either of the previous. Regardless of the need to investigate the cause of a high rate of suicide, it is essential to have them engage with peers. Peers should be an inextricable part of the care of people living with HIV. Peers improve treatment and adherence and generally add to the well-being of patients. Embed peers in the continuum of care, ladies and gentlemen. Why waste a golden opportunity lying on your doorstep? I can remember my first visit to an HIV nurse very vividly. The talk about the ominous secret that I was from now on carrying with me, and the warning that once you tell people you have HIV, you can't untell people. That's very true. But, you know, I was very glad that I actually didn't follow up that advice, because when I got home, I immediately called my best friends and my family, and I can tell you it's the best thing I ever did. I know that, you know, from my experience, this worked in my cultural context. And I know in certain cultural settings, disclosing can be hurtful for people. But let's also look at the facts. Dutch research showed that 80% of the people benefited from disclosing. So let's at least encourage people to disclose to a limited number of people, or bring them in contact with peers. Think positive. Think in gains, not in losses. Medical professionals play a leading role in the experienced severity of having to live with HIV. And I can tell you, we're not in Kansas anymore, Toto. It's 2017, not 1984. If we want to reduce public stigma, we can't do without large public campaigns to enlighten the general public. It is as simple as that. In the Netherlands, we started a very uplifting HIV awareness campaign. It's called HIV Out of the Closet. I know you can't reach Dutch, so I'll just translate what you see here. And it's a campaign from our organization together with an HIV magazine called Hello Gorgeous. Isn't that a beautiful title for an HIV magazine, Hello Gorgeous? Well, it's designed to debunk HIV myth and common misbeliefs. So the first poster reads, I have HIV and 2 beautiful children. And the other one reads, I have HIV and I will get just as old as you. And the third reads, I have HIV and the Lord loves me. And the fourth reads, I have HIV and I'm attracted to women. And I have to say that in the Caribbean context, that doesn't make any sense. But given the Dutch context, yes, because when you tell people that you have HIV in the Netherlands, and you're a man, they assume that you're gay. So this is focusing on the Dutch prospect. So I wouldn't sort of copy that for the Caribbean context, but whatever. Just moving that. Last but not least, we need strong destigmatizing messages. You know, voila, here's the t-shirt. Like you equals you. We need you, the healthcare professionals, to embrace and endorse it. People living with HIV need your support because destigmatization starts with dismantling fear, and your word has more clout than mine, let's be honest, because you as medical professionals, you are on a higher pedestal than I am as an activist. Besides that, it's unethical to withhold people living with HIV information about their bodies and the fact that they are no longer infectious once in care. To dismantle unnecessary fear, we need strong and simple messages. Come on board of the U equals U train. And if you're already on it, enjoy the ride. Let's take a stand together and fight HIV stigma. Thank you for your attention.
Thank you, Alexander. We have a few minutes for questions just before lunch.
Yeah, good. Still morning? Still morning. Good morning to everyone. I wanted to just say a special thank you to Alexander for sharing and for, to me this, I think, is going to be one of the highlights of this meeting. But I know we are, for time, but I just wanted to say something quickly. The year was 1995, and I was the chief pharmacist at the Queen Elizabeth Hospital, our tertiary institution here. And I received a call from the chief medical officer, and she told me that she was sending this patient. We must start the mother to transmission, whatever, we have to give her AZT, and I said, fine. So I sat down in my office, and I was looking for this dejected, haggard-looking woman to come or something like that. And I was just looking and looking. I came outside, I saw a couple, a beautiful lady, a symbol of good health and everything. And I looked away, I didn't think it was her, because the pregnancy wasn't showing, so I didn't. So I sat back and I said to my secretary, please, I'm expecting a patient, let me know. When this patient came, it was that same lady that I have seen, a perfect, healthy-looking woman. She was there with her husband. She shared her story with me. She was a virgin before she got married to her husband. She contracted the HIV virus. She had the full-blown AIDS. He didn't even know that he was HIV positive. So for her to be told that she had the full-blown AIDS, it was a shocker for her. And when she told me her story, we hugged each other, we cried together, and I must admit, I did lose contact with her because she wanted me to be the godmother of the child, and because of my religion, I couldn't. But she misunderstood it, but I just wanted to say that changed my whole opinion and perspective towards the HIV/AIDS, because before I thought you made it on yourself. But to see a lady who kept herself, married a virgin, got married, and the beauty of it all was they were very much in love with each other. And the husband was so sorry because he didn't even know he was HIV positive. So I just wanted to say to you that I've taken a stand against stigma already. I learned it and I saw it, and I really appreciate your presentation.
Thank you.
Yeah, just one quick question, Alexander. Here, as health practitioners, we tend to isolate HIV a lot and kind of keep it in a box. Now that we're seeing HIV more as a chronic disease, you were saying that you were told not to speak out and say, but you opted against that. So it's good that you can speak out. I'm wondering, are you seeing that we can address stigma and a lot of the discrimination if we have persons come out more and treat HIV as another chronic disease, just like how we would treat diabetes or hypertension, etc.? Have we moved along that paradigm that we can come boldly and say HIV is just another chronic disease and therefore we need not to stigmatize? Are you seeing that we've reached that stage from your standpoint?
Thank you for the question. I think it's an excellent remark. And I'd say that, yes, we've reached that stage by a long time. I think it's time for HIV normalization. Now, because HIV, we have all the means in place to in my world, in my country, it is already a chronic disease, and it's regarded as a chronic disease. So depending on the context that you're living in, and you know, I know in Barbados you've reached quite a high level of HIV care. I think in these circumstances, it is time to normalize HIV. It's time to see it as just another STI that can be treated, and when you're treated timely, you can live with it and have a normal life expectancy. And that's that message that needs to be brought across to the general public, because we want them to come in and feel no barriers and no shame to be tested.
The last question.
So we've presented a lot of research here, and you and I had a discussion about stigma and how that might affect both the participants and who come into our studies and the results we get, how generalizable those studies are and representative of the larger population, but also the impact on 90-90-90, what was mentioned in the UK about not meeting the goals, even though 90-90-90 was there. And I wanted to have you give us your thoughts.
Yeah, I think, thank you very much for the question, is that what we see is that this last 10% basically, even if you reach 90-90-90, there is this 10% that you haven't reached, and you need to do an extra lot of work to reach them. And it might be that there is maybe some sort of like a bias of what we think, how this 10% is actually, you know, how that 10% is functioning, what they do, what is their behavior, what are the perceived barriers for them to actually either access testing or care. And I think stigma associated to a number of reasons could be stigma associated with homosexuality, or maybe stigma because of higher sexual activity, and being called a slut, for instance. You know, we know the slut shaming, and it's very, very damaging for people to be called a slut, because nobody wants to be called a slut. So we need to be aware of that there might be this bias which prevents us of actually making programs that fit to this last 10% of people to access care. So we need to look into that. I think we need more data on that.
Okay, thank you. With this, we end session 6. Bon appétit à tous.